Alrighty. Got it. Hi, everyone. My name is Anthea Pitysingh. I am a doctor of physical therapy, and I also am a specialist in pelvic health and pelvic floor therapy. I became a physical therapist about 7 years ago, 2016. And I started off in orthopedics, so general physical therapy, working on joint pain, specifically back pain, knee pain after surgeries, general rehab, even working with patients with neurological conditions, so stroke, TBIs, Parkinson's, muscular dystrophy, and those types of conditions as well. As I began to travel and work in different settings, I got to know pelvic floor as being something my patients were experiencing. So that happened maybe about like 3 years after I became a physical therapist. And my patients were asking me, why do I have urgency to use the bathroom? Why do I have pelvic pain? Can you help me? Why are my abdominals hurting? Why can't I get rid of this hip pain or back pain? And I've been to physical therapy for more than 6 months to a year. Why are these problems not going away? Um, and from that instance, I started doing my research and became more aware of pelvic floor and our pelvic floors and that we have it in our bodies. And I did my research and I found out that you could specialize as a physical therapist in pelvic floor. So from then, I started doing more research, especially on women's health and women's advocacy, but because for me, that's a really big part of my career, my mindset that I want to advocate for women and women's health. So in that sense, I started doing more research in that end, got my first pelvic floor therapist job where I was working in a clinic for about like 2 years or so. And from then I started being more experienced in pelvic floor issues and concerns. That includes prenatal, postnatal, endometriosis, menopause, um, just general urgency and incontinence, even constipation issues, and pain with sex. So from then, I started working with clients every day, full time, pelvic floor, working with those concerns and issues that especially women had. And then last September, I started my own practice in pelvic floor, pelvic health, and orthopedics as a physical therapist. So that's the intro to me and where I'm at right now. So I'm growing in my field and growing in pelvic floor and just expanding my knowledge and expanding my skills and serving men and women. So I do serve both genders in pelvic floor therapy and helping people really connect to their pelvic floor, knowing that it shouldn't be a quiet subject. We should be able to address it and be comfortable talking about it as it's a really big part of our overall health, wellness, and well being. So that's my intro to how I started. What I want to start with is letting you guys know what we'll be talking about. First, I want to give you guys a little bit of an anatomy of the pelvic floor. So basically, the pelvic floor is, I have my model right here actually. So this is what our pelvic floors look like. This is going to be your hips here. And then towards the back, you have your spine. And then here you have your sacrum, so your sit bones. And your pelvic floor really connects directly to all those muscles and bones that we have in our hips and our low back and our sacrum. So here is mainly what we have in our pelvic floor, looks this way. And then on the inside, we have all our organs connected. So you see how closely related our pelvic floor is. Here, back here, we have our rectum towards the posterior side, the back. In the middle, we have our uterus. And then towards the front, we have our bladder. So all of these are connected to our pelvic floor and our spinal joints and our hip joints. So back to anatomy, we have different layers of our pelvic floor that I work on with therapy, and I'll talk about specifics with pelvic floor therapy in a bit. But pelvic floor, we have, well, this is a woman's anatomy. We have our vagina here, and then back here we have the anus. So that would be the first layer of your pelvic floor, and that's the superficial layer, the things that we can see and we can kind of touch. And then I'm going to remove these organs so we can see our second layer. So a second layer is going to be a little bit deeper. So you kind of pass through inside of your first layer, superficial layer, into your second layer here. So it looks like a bowl right there. And then that is where our bowels and our bladder function, kind of like a drawstring. So that second layer is in control of our sphincters. So our sphincters to help us use the bathroom, and also for arousal as well. And then we have the third layer. So the third layer is more towards the top. Oh, is something going on with the screen? I'll continue. The third layer is going to be more towards the top, that's actually connected most to your core. So imagine your core being right here and your diaphragm. So your diaphragm's here and your pelvic floor is directly connected to it. And that's your third layer. So that's the deepest layer. We can't really see it, but we know that it's internally connected to our core and diaphragm. So therefore, breathing is really directly related to our pelvic floor. So we have all our organs going back in, and we can see that when those are affected, when we have urgency in our bowels or bladder, it's going to be directly related to our pelvic floor. So there is the anatomy we're going to start with. And let me show you again our back, our sacrum, our hips. So when we do have hip and back pain and sacral pelvic pain, it could be related to our pelvic floor. And I'll talk about that a little bit later as well. When we think about connections to the nervous system, that is going to be pelvic floor as well. So our pelvic floor is nerve rich. So there's a lot of nerves that innervate. We have the pudendal nerve, we have the sacral nerves, we have our autonomic nerves. So those autonomic nerves, like I was saying before, include the vagus nerve. So the vagus nerve helps with our relaxation, our calming effect, our digestion, even our fight or flight response. So when we think of those nerves being innervated with the pelvic floor, if we feel anxious or stressed or just like scared or just uneasy, our pelvic floor is going to react to that. And that's why sometimes we clench. Sometimes we feel really tight down there, even like our glutes, our calves, our jaw. When those things clench, those parts of our bodies are responding to autonomic changes, parasympathetic, sympathetic changes, and also are directly related to our pelvic floor. So a lot of the times when we feel anxious or stressed, we feel like we have to use the bathroom, or when we're not as calm, we clench up and feel constipated, or when we are about to have intercourse or intimacy, maybe we tense up in that way. And that's also our body having an autonomic reaction to what's happening. And a lot of the times, my patients or patients in general that are having pelvic floor therapy, they've gone through trauma. So they have a really hard time connecting to their pelvic floor. Their sensory reaction, sensory nerves are not communicating well with the pelvic floor. So that's a very important part of my therapy when I'm treating a person that has been through trauma, we really work on the connection and finding the pelvic floor, whether that's through internal or external, or even just deep breathing and just feeling our bodies and realizing that there is that connection there. Okay, more about pelvic floor therapy. So, pelvic floor therapy, you can specialize in as a physical therapist. What I do in my sessions, it is a mix of internal and external care. So, first, I obviously get my patient's consent, and these patients can range from having pelvic pain to pain with sex, or even just hip or back pain, prenatal, postnatal, if it's appropriate. So that's a realm of the patients that I work with. When I do my pelvic floor therapy initial session, we go through questions like a typical evaluation, pre-medical history, what's going on, what are their complaints, what are they experiencing, and just clinically judging where I should go if that patient requires internal care or external care. If it's internal care, it is me going in manually, so a finger or a two-finger exam, and just gently assessing my patient's tissue. So that would mean that first layer of the pelvic floor, so the perineal tissues. Those tissues are the most sensitive, really. And then what I'm doing is I'm just assessing the mobility of the tissue, if it's tight, if it's sensitive. A lot of patients who do experience painful intimacy, even light touch in the area of the outside of the vagina will cause pain. And any other symptoms, even vomiting or feeling uneasy or feeling like they're sick. So a lot of sensory changes and a lot of sensory assessment when I'm doing my pelvic floor evaluation. Then I go in a little bit deeper, about 2 inches after that, into the second layer of the vagina. So that is where a lot of your sphincter muscles are, like we were saying in the beginning with the anatomy. So I'm assessing whether those muscles are painful, tight, if my patients can feel them, if they have any sensory changes. And then third layer will be about like 3 inches. So about here, I can either do one or two fingers, depending on how comfortable my patient is. And then when I'm at that third layer, which is about 3 inches here, I can feel the piriformis. I can feel the inner thigh muscles. I can feel even the coccyx, so I can feel my patient's tailbone. And that way I can assess the mobility of that, if there's pain there. A lot of times my patients will have sensitivity because they sit a lot from working from home. So I can feel that tension if I'm up in the third layer. So I'm feeling all the muscles from layers 1 through 3. And then sometimes my patients also have referred pain. If I'm internal, they'll have pain in their glutes or pain in their knee or pain in their thigh. And that means I'm hitting a specific muscle internally that's closely related to an external muscle. And that gives us a lot of information on where our treatments should go, in a sense. And then also I'm checking my patient's strength. So I'm checking their pelvic floor endurance, their ability to hold, their ability to relax. And you all might know that as a Kegel. So I have my patients do that to assess their strength and their ability to relax. So for a normal functioning pelvic floor or pelvic floor muscles, we want to have the ability to contract, so contract into your Kegel, but also the ability to relax. So those are the things that I'm checking, and I'm checking your ability to hold a contraction, to hold it for about 5 to 10 seconds, which is technically like normal functioning. And then your ability to let things go. So let my finger go, relax, and in turn be able to relax your muscles like your thighs or your glutes and things like that. So all of those things I'm assessing as well in my internal exam. I'm also assessing for prolapse, and this is common for my patients who are postpartum or have been postpartum for years. So I'm checking to see if there's any prolapse of the vaginal or rectal tissue. I can assess that internally as well. And then we have external. So externally, I'm assessing your abdominal tension. If you have tension on the outside, so your lower belly, that's where a lot of my patients hold pelvic tension, is the lower belly, the thighs, the hip flexors, the glutes as well. So I'm assessing the muscular tension there externally. Another important part is assessing breathing. So I am going through a diaphragmatic connection. So our diaphragm is our breathing muscle. I'm checking to see whether or not that is being used efficiently. So if a patient is able to take a deep breath, relax, that's going to be more indicative of a optimal pelvic floor, movement of the pelvic floor, that my patient can breathe properly and be able to relax those muscles and use the diaphragm how it's supposed to be used. And externally, I'm just also doing a whole body approach. So I'm assessing my patient's range of motion of their legs, how they're walking, their posture, any other tension that they're experiencing, even in their upper body, their neck, their jaw. Because, like I said before, everything is really related to the diaphragm and how you're able to relax and contract and how you're able to mobilize your pelvic floor. So it's definitely a whole body approach in that sense. And of course, if my patient is having any other sort of symptoms, I'll go into it. Let's say they're having neurological symptoms, I'll do neurological testing. And if I have athletes, I'll have them maybe walk or run for me, do some squats, do some exercises. And a lot of the times with my prenatal or postnatal, I'm having them do everyday activities to see if they're doing the proper body mechanics and having proper posture, also having proper ergonomics if they're working from home. So all that is what I perform in my pelvic floor assessment. So internal and external. So now a little bit more about the populations that I serve. So again, I'm working on just general pelvic health patients. Specifically, I do work on endometriosis, menopause, and for that, it's a lot of internal care, a lot of relaxation, a lot of internal trigger point release of those tight muscles in conjunction with breathing. So those two I work on a lot, just down training and trying to get that connection for the pelvic floor and the diaphragm to work together efficiently. A lot of my menopausal patients, they have vaginal dryness. So I do work in conjunction with OBGYNs in creating a plan of care for them that involve internal and external care, and mostly to decrease their pain and increase the amount of vaginal lubrication that they have. So that's another population that I work with. I work with prenatal, so pregnancy, getting my patients through pregnancy with birth prep, and that includes working on pushing techniques, breathing, stretching, being able to provide an exercise program that's going to work on stability and decreasing pressure in the stomach, the round ligament, decreasing back and hip pain, providing them with any other devices, equipment that I recommend, like belly bands, going through body mechanics, getting in and out of bed. Transfer training is really important too. And then I provide perineal massage in their at 34 weeks, we do perineal massage. So that is relaxing and mobilizing the superficial tissues of the pelvic floor, called the perineals, and they go about like 2 inches deeper. So at that time, I'm able to go a little bit internally with my patients at that stage of pregnancy and work with them to relax those tissues, which research has showed that that will promote less tearing during delivery. So that's really important, a really important part of my prenatal care. And then going through all the pushing techniques, pushing prep, pushing positions. We go through everything. We make sure, or I make sure, that my patient is really prepared for birth, whether that's vaginally, they're prepared for a C-section. I also prepare them in emergencies just to let them know that things can happen, getting them ready and prepared for either scenario, if that's the case. I also provide C-section rehab. So if one of my patients did have a C-section, we're working on mobilizing the scar, which is very important for after birth. A lot of my patients are uneasy when it comes to their scar. So we work on sensitivity training and learning how to connect back to your body, connect back to your pelvic floor and the rest of your body. So C-section care is very important in pelvic floor therapy for me. Postpartum care as well. So my patients, once cleared with their OB, are able to come see me for internal and external care. So that involves going internally as well and assessing if there is prolapse, if there is a decrease in strength, or if there's any trigger points. So we go in through there and just create a rehab program to get them back to fully functioning as they were prior. It does take time, at least 6 months to a year for our physical therapy program. But at that time, my patients are a lot stronger postnatally with pelvic floor therapy and a lot of exercise program and treatment in that sense. And that also includes DRA, so diastasis recti, which I treat a lot. Other things, bladder urgency, frequency, incontinence, and that also has relations with constipation and fecal incontinence as well. So I work with patients with those conditions. And then also chronic back and hip pain, like I talked about. A lot of the times people are having unexplained hip and back pain. They don't know where it's coming from. So once they are able to get a pelvic floor exam, they are able to connect more to where those issues are happening. A lot of times it is internal with trigger points that are internal and tight muscles, and they're having trouble and difficulty relaxing. So pelvic floor therapy is really beneficial for chronic hip, back pain, unexplained pains there as well. And then also pain with intimacy and intercourse. So my patients will come see me if they have either pain with insertion, deep pain with intimacy or intercourse. So I work a lot with internal care, releasing trigger points there, down training, relaxation, working on their strength if they need it. So that's another population that I work with. And then also, like I said, trauma survivors. A lot of my patients do have trauma, especially my pelvic floor patients. So we're really going in and looking at the body as a whole, breathing, down training, relaxation, getting the vagus nerve going, getting that calm, relaxed feel back, and that they are connected and know that their pelvic floor is there and that I'm there to help them. So that is a little bit of what I serve and who I serve and the populations that I do. So I think when it comes to pelvic floor therapy, there might be a big stigma. So I really, really want to express how important it is to just talk with patients, let them know that this is a part of the body. It is a part of our emotional well-being, our emotional connection, and very important just for wellness overall to know that connection is there with your body, and things that are happening, let's say incontinence, pain with intimacy, all those other concerns are directly related to pelvic floor. So really important to talk about it and just make your OBs or MDs aware that you are experiencing these things. And there is therapists like myself out there that we specialize in helping these concerns. I know maybe you go to an OB's appointment and it's 30 minutes or so, and you maybe think, oh, my issues haven't been solved. I feel like that's when pelvic floor therapy should be incorporated in an OB's visit or MD's visit. That although our session is this amount of time long and we're talking about medical issues, there are therapists that will help you through these issues and you can get treatment for this. So that's really important that I really want to stress. Um, Referrals for me come from orthopedic doctors, internists, OBGYNs, especially, and that has to do with any sort of pelvic health concerns and orthopedic concerns. When it comes to my OBs, they're referring me for general pelvic health, menopause, like I said, endometriosis, PCOS, prenatal, postnatal care. And then my MDs are referring me for unexplained pain that their patient is having. They can't move in a certain way. They're having trouble lifting a box or squatting or returning to their workout program, which they're not used to. So, those are scenarios where pelvic floor therapy can really help. Um, yeah, so I think that was my pelvic floor presentation.